Yes, in part. The baby blues, though, are so common. They actually occur in about 80% of all women, and so common that we don't call them a disorder. That's the normal, essentially expected hormonal fluctuation, mood disorder that can occur, but resolves on its own in a couple of weeks with support and some understanding and some sleep. So that's very different from a perinatal mood or anxiety disorder, which occurs in up to 20% of women and is more persistent with those longer periods with an associated level of dysfunction. The perinatal mood and anxiety disorders are medical illnesses. There's a hormonal and chemical imbalance that's occurring that can be treated either with therapy for some of the more mild cases, but for a good majority would require antidepressant or anxiolytic medication. There's a vulnerability, but each pregnancy is different. So even though you had one episode postpartum after one child, you may or may not have it after another child, but you are at a heightened risk, and we would consider you more of a high-risk pregnancy in that regard. Women are also, who have this vulnerability, may be more at risk when they reach menopause and have those hormonal changes as well. I've treated women from neonatologists to lawyers to prison guards to housewives, so the whole spectrum of women can and do suffer from these disorders. I've had women who have been so disabled that they were unable to attend their own child's christening and have come back to me, an entirely new woman, herself again, thankful for getting the help that they needed and the treatment they needed. There are women who go from not wanting to be with the baby, wanting to run away, feeling like they screwed up their marriage and their lives by having this child, unwelcoming of the child, to, when treated, fully bonded with and functioning fully in their family. It's a wonderful, in some ways, illness to treat because there is such a nice recovery, and the impact is so great of having a woman and her family. The whole family's impacted, really. The dad's impacted or the partner's impacted. Having the whole family get their wife, mother back, it is really a wonderful thing. And the women are so grateful. Some of them, many of them, have never had a brush with behavioral health providers before, and are reluctant to seek treatment. They kind of think, oh, it's just a pull yourself up by the bootstraps kind of thing, and yet get to a point where I give up, I need help. They recognize it, or someone around them fortunately recognizes it, and with treatment are back to themselves. So it is a very rewarding illness to treat. It has typically a very nice outcome. I actually use sequential rating scales. The Edinburgh, which is a evidence-based tool, self-rating scale that women can fill out in the waiting room that tracks their anxiety and depression as it improves. So the worst you can be is a high score of 30. I tend to see women who are 26, 27, 28, 29, 30. And I repeat that instrument when I see them for their med management follow-up visits, and they redo it, and you'll see the scores dropping. So women at first may not quite recognize it. They see the scores dropping and then they begin to feel it. But their family, the spouse, the partner, starts to see it and starts to feel that they're getting their wife or spouse back. So we do track, and I chart and I show them the scores, actually. It's really nice to see. 20 years ago, we did have antidepressant and antipsychotic medications, some which were better or worse tolerated. So we had medications available, but we didn't have as many people actually recognizing illnesses. And women would suffer untreated and perhaps eventually resolve, with a big impact on their ability to bond with and care for their baby in the early phases, with some negative sequelae for that developing child. Those that were lucky enough to get treatment had some of the earlier antidepressants and antipsychotics which were less well tolerated, but there were medications and talk therapies available. Today we have newer medications, and in combination with some new evidence-based talk therapies, women are getting better with less side effects and a little bit more quickly. They've done some research and found that some of the cognitive behavioral therapies, or IPT, interpersonal therapy, are really quite successful in treating these women. So rather than the dynamic therapies that have been around looking through your past for issues that have come through your entire lifetime, basically, from your own parents or whatever. These are more problem-focused therapies that look at things like role transition and really target some of the stressors and impact of those stressors in real homework-driven kind of interventions. You might be asked to practice certain things. It's a more interactive, dynamic exchange with the therapist. It's not so much a therapist just listening while you freely talk about your issues, but perhaps identifying specific stressors or specific issues of interpersonal conflict and identifying them for the woman and having her then perhaps practice those, working through those conflicts. Simply first by identifying them and then talking through with their spouse. It could be that my husband doesn't help me. My husband doesn't do A, B, or C with the baby. Something of that nature, where the woman has sort of a black and white idea, and in fact, they're encouraged to explore some of that and think of ways that they might communicate more directly what it is they're thinking or feeling. So my husband doesn't help me, therefore he doesn't love me, therefore he doesn't care about this baby, and that whole sequence of events is interrupted with some reality-based. You see yourself going from 0 to 100, my husband isn't helping, let's identify exactly what he is or isn't doing, and perhaps identify ways to reinforce the behaviors that you would like, or to speak to him about what it is that you need at this time.